Well, it's my privilege to present the 2025 J. Rue Invited Lectureship. Dr. Rue, who practiced in West Virginia near us, and I got to know him very well, was an incredibly energetic, personable, and compassionate human being. In addition to his immense productivity, he was known as being an incredibly innovative hand surgeon with many patents and ideas. He was the chief of the hand division at West Virginia after his fellowship with Dr. Kirk Watson. He was always searching and changing our field, and he was tragically taken from us from a freak accident from a wave that broke his neck and gave him a C4 tetraplegia, which ultimately led to his succumbing. It is only appropriate that our speaker this year is as innovative as they come and as energetic as they come. Dr. Andy Koman is at Duke Blue. He leads Duke Blue before he went to Wake Forest. Duke University, AB, Duke University Medical School. He did a pediatric internship before seeing the light and becoming a general surgery intern, followed by orthopedics, and then did his fellowship under the auspices of Dr. Urbanik. Andy was professor and chair at Wake Forest University from 2004 to 2024, and during that time, he created a very vibrant institutional lab and a residency that was widely regarded as a diamond in the rough. Andy's leadership is impressive. President of the EOA, president of the SOA, president of the American Society for Surgery of the Hand, multiple NIH training grants, and he is the only recipient of 2 Kappa Delta Awards, which are the highest award that the AAOS offers. So, without further ado, I'd like to introduce a great friend, teacher, father, grandfather, and a wonderful husband to his wife, Lee, for over 53 years. Andy called me on Friday and said he was feeling great. He had just had a stent placed, which had alleviated all of his anginal pain. And on, I guess that was Thursday, and on Friday morning he called me and said, you know, I think I had a lot of Versed on board last night. So I think he overextended himself a little bit. His doctors advised him not to travel to Hawaii, as you can imagine. So Andy is joining us via Zoom from sunny, brilliantly warm North Carolina. And Andy, I see you're there. So we miss you and looking forward to your talk.
Well, thank you very much, Dave, for that great introduction. Can you hear me okay?
Great.
Yeah, it is sunny here, but it was 26 degrees when I came to work, so I'm not wearing a Hawaiian shirt to try to stay warm. I wish I could be there with you. I am feeling pretty good. But, you know, you should follow doctor's advice. So it's my pleasure and honor to present this. I've known, trained, and worked with Dave for a long time. And obviously hand surgery is an incredible importance to me. So I'd like to share with you this morning a little bit about the diagnosis and management of upper extremity occlusive disorders, putting it into context of Jay's innovation. I don't have anything to disclose. I'm going to briefly discuss FDA-approved drug of off-label indication, but that'll be very obvious. Innovation is transformative. And I knew Jay for 40 years. I have a house in West Virginia, and I used to see him, and having this honor that supports his memory is incredibly valuable and important to me. So transformative initiatives impact existing concepts, and I'm going to talk a little bit about how that is able to be used in arterial reconstruction and arterial disease. The value is it can create efficiency, effectiveness, and address unmet needs, and that's pretty important. And by doing this, we can solve problems by transforming existing ideas. I want to talk a little bit about how we can use standardization to provide innovation. So 40-some years ago, when I first was introduced to ulnar artery thrombosis, it was artery broken, me fix. Well, obviously, that's not the best way to do it. So perception is that standardization contradicts or inhibits innovation. But I'd like to submit that it doesn't. I believe that it facilitates the dissemination of new technologies and encourages research and provides a very needed balance so that you can actually move forward. And rather than prevent innovation, it actually stimulates it. By doing this, it allows us to clarify the evaluation of patients and their problems, to define goals, and in this case, based upon anatomic and physiologic principles, and we'll come back to that. And this allows us to direct care and codifies management. And this results in time and cost-efficient evaluation and management, avoiding unnecessary procedures, decreasing iatrogenic morbidity, improving outcomes, and a platform on which we can build or innovate additional improvement. So a little bit about this journey, of mine at least. So as Dave said, I did pediatrics, but I was always going to do orthopedics, so I was going to do pediatric orthopedics. But while I was a resident, we were doing microvascular and replants, and so I joined the replant team and got involved in actually evaluating microcirculation. And what you're going to see is an application of those techniques that we used to evaluate microvascular perfusion and microvascular outcomes, and how you can project that and move that to vaso-occlusive, vasospastic, and occlusive disease. So my journey in this area started in 1978, and I saw a patient in the ER that had an ulnar artery thrombosis. Miraculously, we got an arteriogram, and in those days, and still I use arteriograms, but Jim Urbanek always wanted arteriogram. And we took this patient to the operating room. We resected the thrombosis. We repaired it under a ridiculous amount of attention. It did have a patency, by patency test, but I'm confident that by the time this patient got to the floor, it had already thrombosed. This prompted me to actually look at Jim Urbanek's patients. And so we published this in 1981, right before I came to Wake Forest. And he had treated, and these were Jim Urbanek's patients. One of them was mine, that probably was one of the bad results. They had 28 thrombosed ulnar arteries. They all had arteriograms, so we knew exactly what they had. And over 50% were non-operative. And in general, they got better. But what was very interesting is that if you look at the symptoms in red, is obviously more involved than the yellow. But pre and post-op, they all post-operatively had symptoms. They just got better. So there were residual symptoms in all these patients, but the treatments didn't correlate with outcomes. I mean, sometimes successful reconstructions, but there weren't very many, didn't do as well as resection and ligation. So there clearly was something that was going on, and it suggested to us that we needed a patient-oriented approach in order to deal with this problem. Now, in 1985, I looked at an additional 47 patients. At this point, we were using the microvascular evaluation tools that we designed for replantation. But these patients, these were all my patients, 100% had pain, 80% cold sensitivity, and 85% numbness. They all had arteriograms, and so we knew how complicated their thrombosis and how extensive it was. But the treatment, once again, was fairly varied because we really didn't have a plan to treat these patients. The physical findings, and so you can see these were fairly severe. They had changes in temperature reflecting total flow. A quarter of these patients had gangrene, so they had significant arterial insufficiency. And there was a palpable mass in 9%. So this is not the general population, but this is what we were dealing with. When we look at the treatment, sympathectomy, and the majority of these were just resection and ligation. We did no cervical sympathectomies on these patients. And in those days, we really didn't have chemical sympathectomy. 17 had arterial reconstruction, and physiologic and pharmacologic drugs, palliation, was all we did in 7 of them. And so what we determined is that, again, the majority improved, but all had residual symptoms. Those 17 reconstructions had an abysmal 80% patency rate. And the resection and ligation was often superior to reconstruction. Of course, these were different types of patients. The ones who had resection and ligation were not as severely involved as the ones that had potentially adequate collateral circulation, but were compromised by vasoconstriction. So at this point, we realized that we needed a way to approach these patients based upon their pathophysiology. And we needed a common goal, which was to maintain or restore pulsatile flow that provided a nutritional component that was able to respond to stress and perfuse nutritional beds. And to do this, reduce vasospasm. Now, obviously, a reconstruction is also a sympathectomy, as is a resection and ligation. So what we determined was that there were actually 3 groups that we could see. First, the patients with good collateral circulation and near normal sympathetic tone. And these are the patients that you really don't even see most of the time, but if you talk to them, they have some mild symptoms. And then patients with good collateral circulation, but vasospasm. And so these patients do well if you can just decrease the vasospasm because their total blood flow is adequate. And then the group 3 patients with poor collateral circulation. So how do we deal with these and how do we approach them? So I'm going to give a little bit of background on occlusive disease, which is thrombosis, aneurysm, and embolism. We're going to concentrate primarily in this talk today on distal. We're not going to look at embolism so much from the subclavian and axillary, but really thrombosis secondary to trauma, which include ulnar artery thrombosis, hyperthermohamer syndrome, radial artery thrombosis, much less common, and peripheral vascular disease, which is different than true post-traumatic, although there's a post-traumatic component. And all of these are in some point exacerbated by vasospasm, although the true peripheral vascular disease is less positively impacted by decreasing vasospasm because of the abnormal changes in the vessels themselves. Now, if we look at this, it's really a significant societal issue. If you look in an Australian study, 14% of workers who used their hand as a hammer had evidence of ulnar artery thrombosis. 9.6% of occupational workers in France with palmar trauma had ulnar artery thrombosis. And this is a little scary if you're an orthopedic surgeon, although this is mostly joint surgeons. 11% practicing over 15 years have ulnar artery thrombosis, usually in their non-dominant hand, but it can be either one. Now, peripheral vascular disease is increasing, so that's important to know. And vasospastic and vaso-occlusive disorders impact millions of people. Now, what's the mechanism distally? Well, it's repetitive trauma, and if you look at this, here's the hammer, which is obviously not what happens, but just banging your hands. This damages the internal elastic lamina, not the intimus so much. And with exposed media and then Virchow's triad, you actually get thrombosis. But it starts off with this periadventitial thickening, which can go to thrombosis, but you also can get, and very frequently we see an aneurysmal component, and we'll come back to the importance of this. So basically this is damage to the internal elastic lamina that then, after external compression trauma. Now, upper extremity inclusion with inadequate collaterals, especially with vasospasm and shunting, can get you necrosis. We do not see necrosis without occlusive disease combined with vasospasm. And the symptoms and signs are then of arterial insufficiency, pain that's even refractory to narcotics, and peripheral nerve irritation, which is why we see numbness. And this produces pain, cold sensitivity, impaired quality of life, functional limitations in the extreme, ulcers and infection, and gangrene and amputation. So how do you approach this? Well, I mean, you're a very sophisticated audience, so I'm just going to go through sort of quickly some of the pearls that I look at, keys. One is suspicion in males, although women get this too, who use their hand in their occupation, unilateral Raynaud's, and a history of stillbirth. Factor V Leiden is the most common congenital coagulopathy. So this is something that, that if their mother had multiple stillbirths, they may have factor V Leiden. And we'll see how this actually negatively impacts reconstruction if that's necessary. When you look at them, you want to look obviously for petechiae, splinter hemorrhage, do an Allen test, and look at temperature difference. Although remember, the temperature reflects total flow and not nutritional perfusion, which is the key. And then, of course, timed Allen test is quite valuable. Laboratory testing is important. Look for coagulopathies, and I'll give you some data on that later. Factor V Leiden, protein S and C, and antithrombin 3, and we test routinely for all of these. And the presence of those has a negative impact on reconstruction. We like Doppler ultrasound. I use this in the office, and it's very helpful. You can use color Doppler as well. And DBI. These are the basic things that are easy to use, that are available almost everywhere, and don't require lots of sophisticated issues. You can do these yourselves, and any hospital that has a vascular lab can give you a DBI. And less than 0.7 gives you impaired function and symptoms, and less than 0.5 very severe symptoms. So this is quite helpful. I use arteriography. People can use CT angiography and magnetic resonance image angiography, but still in most places, cut film with subtraction is the gold standard. And here we see a patient with an aneurysm on the ulnar artery, and you see a tortuous and an occlusion of the radial artery as it dives into the snuff box. Now, when you look at arteriograms, it's interesting. There are hundreds of variations, but all of them have three common palmar digital arteries at the level of the metacarpal phalangeal joint. So if you don't have that, or if you see that, please let me know so I can stop saying this. But if you don't see three, something is abnormal. Now, advanced testing, and you don't need to do this, but this is some of the testing that we used actually to come to the conclusions that I'm going to give you. And we use a cold stress test where we use measure temperature and vital capillaroscopy. We look at baseline, and then we cool it. And this is not ice water. This is not horribly uncomfortable, but patients with collagen vascular disease don't like it, obviously. And you can watch temperature, and it should drop a little bit, and then it should rebound as it is in that upper right-hand corner. Now, digital temperature gives you a good estimate of thermal regulation and total flow, and laser Doppler is vasomotion, but also gives you a relative index of nutritional blood flow. We know that because when we look at nutritional blood flow, we can look at that with vital capillaroscopy. Here is, you can see a microscope looking at just proximal to the nail itself, at the nail fold, and those are capillaries, which are nutritional. And by looking at those, you can actually measure nutritional flow, and it does correlate with laser Doppler. So in my evaluation, I'd get a history, I'll do an Allen test, Doppler ultrasound, DBI, I do a cold stress test, but that's not necessary for you to do in coagulation studies. And then I do an arteriogram on all of our patients. Now you have multiple treatment options, observation, medical, thrombolysis, and then multiple surgery. And I'll talk a little bit about those. Now, one thing I would like to point out is you should avoid transection or proximal sympathectomy. Now, ablative, non-permanent phenol in the old days, which we don't do now, but which you can use radiofrequency ablation where it recovers, it is an option. I don't especially like that, but you can do that, and that is not contraindicated. But if you cut the proximal sympathetic trunk, it works pretty well for 4 to 6, maybe 8 weeks, but then you get an upregulation. So that is not a good thing to do. As I said, radiofrequency ablation is a potential palliative thing that the vascular surgeons may do. Now, what's the natural history of occlusive events? Well, you get some symptoms pretty much no matter what you do, especially cold sensitivity. Your goal is to restore pulsatile total and nutritional blood flow, so you need both. Sympathectomy, unfortunately, does not improve total blood flow, but does nutritional. Hypercoagulable states or coagulopathies have a poor prognosis. We used to think that if it was patent over a couple of years, that was fine, but we found out, just like in the coronary grafts, that veins dilate and rethrombose over time. We found at 10, 11 years, we started getting rethrombosis. You can expect, if you follow basic guidelines, resect the damaged vessels, a patency in the 90%, but not 100%. And sympathectomy improves nutritional blood flow. So those are some key things. So let's talk a little bit about those 3 groups. Well, group 1, that's good collateral circulation, near normal sympathetic tone. These patients don't have collagen vascular disease. This is often an incidental finding. Symptoms are mild. More often than not, no intervention is necessary. The DBI is going to be greater than 0.7, and intervention is rare. So you don't really need to do much with these patients. Now, group 2, this is good collateral circulation, but they have abnormal sympathetic tone, maybe from the acute event, maybe just from some other problem they have. Their DBIs are going to be greater than 0.7. So this gives you a lot of options. You can treat them medically, but if you have to do surgery, you can do thrombolysis, you can, during exploration, you can do peripheral sympathectomies, you can do resection and ligation, and you can expect, in general, a pretty good response. So thrombolysis, we use that sometimes in group 2 and 3, and that can provide some acute palliation, especially if it's an acute event in which they've thrown clots, and you can dissolve those distal clots. You can use it for post-operative graft thromboses, and we've done this not usually acutely, but at 10, 11 years, and I'll show you some examples of that. And importantly, to manage distal emboli and clear things out. There are reports of using this as treatment. Unfortunately, it often reveals an aneurysm, and the natural history of an aneurysm in the hand is that it's going to rethrombose and potentially throw clots. And the rethrombosis, even without anticoagulation, is common. So this is a tool. It's probably not, especially in the acute phase, to clear things out, to give you something you can graft to clear distal events so that you can convert the patient potentially to a better category if they're group 3 to group 2. So here's a patient that had an ulnar artery thrombosis. He had a vein graft, and we see this is like 10 years later, and you can see in slide 1 there, you can see the acute cut there, and then where it went into the out to the superficial arch is sort of gone. You can just see the deep arch, which is what's keeping his hand. On 2, this is after a few hours. A repeat arteriogram shows that starting to refill the ulnar artery. Then you go to 3. Now we're almost to the where the superficial arch should start. And then you go down to 4, it's filling out more, and then you see the superficial arch open up on 5, and now you can see the connection there, but you see that there is an aneurysm that we've now, so this is the vein graft has now become an aneurysm. Additional things you can do is arteriolysis. So this is somewhat short. This is a form of a sympathectomy. And this is unusual, but fairly interesting. So here's a patient, 35, came to see me with acute symptoms. Here's his arteriogram. You see he's being perfused by his deep arch. So he might do fairly well. So we went to look at with a resection and ligation, or to see if this could be reconstructed easily. And what we found was quite interesting. We found this, that there was not thrombosis, there was just constriction of the, you see the ulnar nerve below, of the ulnar artery. And the reason it's hard to see is because there's all this periadventitial scarring around it, where it's scarred down, and that's what it looked like. And after we freed all that up, this is what you see on the right. And this patient actually did well, and I followed him for about 8 or 10 years, and then he disappeared, but continued to do well. And I have seen 4 patients like that. Now, the next thing you can do in group 2 is resection and ligation. This decreases the thrombosis propagation, so prevents further damage, provides a very effective sympathectomy, especially if you make a little incision and do a sympathectomy on the radial side. Doesn't require a graft, so there's no graft morbidity. You can do later reconstruction, and that's possible. And as I said, doing a sympathectomy of the parallel vessel is often very valuable. Now, botulinum toxin has been proposed. Jim Higgins, in the paper in 2015, talked about this. There are no randomized trials looking at that. And obviously, this is not going to correct potential propagation of the clot and is temporary, but it's just something that is out there, so just wanted to mention it. Now, some interesting data. Neil Zimmerman did this very interesting study. He looked at patients who had ulnar artery thrombosis. These were type 2 patients, predominantly as best I could tell. And if they were 0.7 or less, he reconstructed them. And if they were greater than 0.7 dBi, then he resected and ligated them, and that was 6 of those. And so no difference in outcome, pain, and cold sensitivity. So this is very similar to what we saw in those original 2 groups that I looked at and described before. Improvement in 11, and 50% continued to experience pain. Now, there may have been some of these that were type 3 that fell into it, but it's very interesting. Cold sensitivity improved but didn't go away, and patency in 7 of 8. So no one has done the study where they actually did the less than greater than 0.7 and reconstructed them as well. And I'm certainly not going to do that, but that would be an interesting study to do. Now, the one that of course, all microvascular surgeons or vascular surgeons are interested in is this group 3, which have poor collateral circulation, abnormal sympathetic tone, and a dBi of less than 0.7. So by definition, they have inadequate collaterals or vascular insufficiency. And these patients with arterial reconstruction have a pretty good response. Now, how do we define poor collateral circulation? Well, an incomplete superficial arch, if the thrombosis extends past the common digital arteries, so by definition, the collaterals, even if they're there, can't get there. If you have a clot and you put distal emboli, so that's going to give you a 2-level issue, diffuse lesions, and injury to the parallel vessel, so the collaterals can't function. So here's a patient who came to see me, and you can see he's got on his little finger, which had significant pain, cold sensitivity, severe rubor, and rest pain and delayed healing whenever he cut or did anything to himself. This is what we saw when we explored him. It paralleled his arteriogram, and you can see the tortuous aneurysm going all the way from the ulnar artery out to the superficial arch. And then to the right, you can see clot going out to his finger. I've dissected more distally, and at the PIP joint, we did find a patent vessel. And so this was what we did. We reconstructed the superficial arch and then did a limb of this graft all the way out to the middle of the middle phalanx, where we did a V resection to make it fit. Miraculously, this actually stayed patent in spite of the fact that this patient got drunk and dehisced his wound. And at 10 years, miraculously, it was still working, and then he disappeared. So poor collateral circulation, what happens if they rethrombose? Well, if they truly have poor collateral circulation or inadequate collateral circulation, the symptoms come back. And I've, fortunately or unfortunately for the patients, fortunately for us to know what happens, is that if you can establish flow or after with arterial reconstruction, that they get better. So, but if they thrombose, they get recurrence of symptoms, their function deteriorates, their vascular perfusion changes, but if we can restore that flow, they get better. So we don't want to do that. Now, what about the impact and comorbidity of these following things? Coagulopathy, collagen vascular, systemic disease, time, and some technical issues. Let's talk about those. Well, George Chloros looked at my patients with greater than 2-year follow-up, and if they had abnormal coagulation or a systemic disease, that was 37 of them, the patency rate after successful reconstruction was 83%. If they didn't have any of those things, it was 93%. It was 100% for a very brief period of time, but follow-up confirmed that I had a couple clot off later, so it was 93%. Dave Rush actually looked at this study for me, and he looked at 23 patients, and they all had 2-level occlusive disease. So by definition, they had inadequate collaterals. So they had a reconstructible lesion at the radial or ulnar artery proximally, and unreconstructible emboli or thrombosis distally, and all had signs of arterial insufficiency. What we found is, so there were 20 ulnar arteries and 3 radial arteries, and this drawing on the right is actually an example. This was a patient who was, not by me, but was ligated. Unfortunately, they ligated his common digital arteries as well as his ulnar artery at the wrist, and he came in 6 months later, and we reconstructed him with an endoside graft into the radial artery, and then a blind pouch with endosides of the common digitals. So you can reconstruct these patients later, although it's better if it's a much shorter segment. What we found was this patency resulted in improved microvascular physiology, and that directly correlated with improved quality of life, function, decreased pain, and ulcer healing. So that's valuable. So here's an example of a patient who had, in 5/10/94, had a repair with a vein graft. It clotted off. This is that patient you saw earlier, clotted off with, when it became aneurysmal, we opened it up with urokinase. We used the inferior epigastric artery to reconstruct it, which was a perfect fit. So this is a patient who at 10, 12 years clotted off, and we reconstructed him. So arteries, we believe, will do better, and we offer patients, certainly under 45 or 50, or even a little bit older if they're using their hands a lot. If they'd like, we offer them artery grafts. And here's his scar. Now, how can you improve patency? Well, the key is to resect damaged vessels. And early on, we thought this bottom right maybe was pretty good, but that's not what a good vessel looks like. So you want to manage size discrepancy. And I use lower extremity veins. I know many people use upper extremity veins, but I use lower extremity veins. I think they last longer. They are sturdier. So here's some keys. Resect all the damaged vessels. And one way you can do that is resect beyond a patent branch. And so this is what the vessel should look like, not that vessel before. And we'd cut that back even further so you have pristine vessels. You want to manage size discrepancies. You want to avoid tension. It turns out our average grafts were over 10 centimeters. Obviously, this is a referral practice, but we use long grafts, and we use that rule of graft to go proximal and distal to a patent branch, and that helps. You want to manage size discrepancies. You don't have to do this much with arteries, but these are just some of the techniques that you can use. And as I said, you want to use lower extremity grafts if possible. And then you're doing a sympathectomy where you're reconstructing, and I like to make a small incision and do additional sympathectomy of the radial artery or the ulnar artery, depending on which one you're reconstructing. So the natural history of this is adequate collateral circulation in groups 1 and 2, have persistent but decreased symptoms and good function. Inadequate circulation in group 3, there's no improvement unless you intervene, and they can get ulcers and gangrene. And arterial reconstruction, if successful, will improve function and increase blood flow. And that's how you increase blood flow. The sympathectomy only directs it to nutritional beds. And rethrombosis gives you re-exacerbation of symptoms and signs. So type 3 patent grafts improve outcome. Patency is impacted by technique. Arterial reconstruction increases total flow as well as nutritional flow. And sympathectomy is primarily nutritional flow. So our treatment goal is pretty simple. So we've standardized things to restore pulsatile flow responsive to stress. So by standardizing things, we can get to a patient-oriented approach that decreases inappropriate flow. You need to be aware of hypercoagulable states. And there is a little bit of morbidity from a lower extremity donor site, but that usually goes away in a few months. Now let me talk for just a minute about a vasospastic disease. We already talked a little bit about it. Digital thermoregulatory dysfunction affects a lot of people, and it's becoming more and more of a burden. 10% of the general population and 20%, especially of premenopausal women, have significant cold sensitivity, and it impairs health-related quality of life, and severe, especially in collagen vascular disease with systemic sclerosis, right now the worst, since we have no biologic treatment for that. Now, Raynaud's severe vasospasm plus occlusive equals cell death. And you can have pain, but you usually do not have cell death without an occlusive event. The pathophysiology, if you look at the literature, says the vessels are normal. Now, they're really not. There's increased periadventitial tissue, and the sympathetic nerves are not working right, but grossly they're fairly normal. Their vasomotor abnormalities are very obvious. They are hypersensitive. There is increased alpha-1 and alpha-2 activity, and that's where the shunting occurs. And there's abnormal nutrient and thermoregulatory control. So physiologically, these vessels, while they look histologically pretty good, they're not normal. Management of the disease is important, especially in collagen vascular disease. Pharmacologic, environmental are important, and then we can do sympathectomies and as a last result, arterial reconstruction. In collagen vascular disease especially, which are the ones that we will see the most, the traditional interventions and biologics are commonly used. First-line management is calcium channel blockers. You usually won't see these patients. The rheumatologist or the internist will be managing them, and calcium channel blockers is the primary management. And most patients can be managed with this until they get occlusive events or their disease becomes rampant, especially in the systemic sclerosis patients. Physical modalities are helpful. Biofeedback was really big in the 80s, 90s, sort of fallen out. It really never helped that much, but it helps a little bit. Heated gloves and the new technology with small lithium batteries has been incredibly helpful to my patients, at least. and then changing their environment. It'd be much better to be in Hawaii with you guys than it is to be here if you have a little Raynaud's. And then the chemical sympathectomies, botulinum toxins. Now, these work by blocking snare proteins. In blood vessels, these improve nutritional blood flow, and that they work at an alpha-1, alpha-2 level. The acetylcholine, which is blocked in muscles, is not what really happens in the blood vessels themselves. Tom Smith in our lab showed years ago, this is what happens if you block alpha-1 and alpha-2 receptor transmitters, but by cleaving snare proteins, you increase nutritional flow and arterial diameters significantly. And so it showed this back in the late 90s, is incredibly valuable in treating these patients. There have been 5 randomized controlled trials as of a couple of months ago looking at this, but these drugs are not labeled. Botulinum toxin, if they are indicated, would be for refractory disease. They are not valuable prophylactically and should not be used that way. They are not FDA labeled for vasospastic disease, but all these drugs are FDA approved, so these are off-label indications. As I said, they work at the alpha-1 and alpha-2 neurotransmitters. Efficacy is a little longer in many patients than it is with muscle for spasticity, and somewhere between 4 and 12 months. 100% of patients get intrinsic weakness, so this can be a problem. Obviously, piano players, people like that, this would be a big problem. Usually this is gone by 2 to 4 weeks in terms of clinical import. It does and is quite effective. It's a chemical sympathectomy. It's a very powerful one that maximizes nutritional flow. It will heal ulcers if there's adequate total flow. And you can't always tell. Like with periarterial sympathectomy, the use of botulinum toxin works if there's adequate flow there. It just maximizes your nutritional flow, which is only about 8 to 15, 20% of total flow. So you don't need a lot of nutritional flow for tissue not to die. And of course, there are insurance issues since it's not labeled, and we have a great deal of trouble getting it paid for. Often the patient has to pay for it themselves. Occasionally, some private carriers will pay for it. So the treatment of this is microvascular shunting. You can do thoracic sympathectomy. You already talked about that. Try not to let them cut it. Radiofrequency or phenol, that type of stuff will work. Resection and ligation of the thrombosed vessels, or Lariche. That's not something that we do very commonly for vaso-occlusive disease or vasospastic pure disease, but we sometimes do periarterial sympathectomy. And if you can, and Wendell Merritt has shown this very successfully, as others, if you can, and we do this routinely, if you can reconstruct a vessel that's occluded along with it, that's helpful because that improves nutritional and total flow. The techniques, original technique for the finger were described by Flatt and Wilgus. It's a Brunner incision, exposes the distal palmar to the interdigital web. You do adventitial dissection with operating microscope. Strip the vessel. You don't really do an adventitial stripping, you do a periadventitial stripping, and then cut the connections between the digital nerves and the arteries, and this is very effective. We developed a technique that would allow you to do this for the whole hand more quickly. There's a 2-incision technique, which but this is a very effective technique, and if done correctly, allows you to cut the digital nerves and strip the radial ulnar artery as well as the deep arch. So just an example is a patient, 41-year-old with mixed connective tissue disease, refractory Raynaud's. Here's the arteriogram with significant vasospasm. With vasodilators, we could get this to open up. Let me see if I can get this to play. So here you see the patient, this little rubor of arterial insufficiency. This is very important. You really need to exsanguinate it. This is the incision. in the distal palmar crease. And the key to this, I mean, someone did describe doing it 2 incisions. You can get everything with this, but the key here is go straight down to the palmar fascia, and then right on the palmar fascia, so you've got a nice flap, you have to elevate proximally and distally. Here we're actually just looking at some of these vertical septi to free them up, but we're leaving a lot of that palmar fascia, I'll show you, so we can open it up proximally. So this is the key. You've got to really get this, so you've got these nice flaps. If you do this and then you invert the edges when you close them, you get a very nice scar. And if you need to, and you need to do a reconstruction, you can actually extend this proximally. Here we see cutting it. As you see that now, as you cut the fascia, palmar fascia, and then get those deep connectors, things open up. Just bipolar cautery. And so you have to get this so it's really freed up. And we'll open this up a little bit more. And now we're seeing the common digital. So now you get all your common digitals, and you get them all the way out past the almost past the metacarpal phalangeal joint by doing this. And now we see the superficial arch. I'm coming out in the common digital vessels. You can see the nerves underneath. And then we put vessel loops around. Now you can see there's a lot more periadventitial tissue around these than you get if you don't have the vasospastic component. And here we're going back towards Guillon's canal. You can actually get all the way back into Guillon's canal here, and then pull the vessel distally so you can get to it. And then just as this periadventitial tissue is removed along with the vena comitans, and then you can coagulate those. So then we put vessel loops around all 3 common digital arteries, and here you can see where they're coming off, and there's the superficial arch proximal, and the common digital to the long ring there, and then farther back is the ring little, and then out to the index long. These are the vena comitans. We're taking those off. And then you get in this plane right here. There's this little plane, and then, so there are 2 planes, one that takes the vena comitans off, and then one that takes the periadventitial tissue off. So this is done under loop magnification, and we'll come in with the microscope. So that's what you get. You need a little bit more, so you want to free it up, you just make a little bit of incision here at the end. And as I said, you can actually, if you find a thrombosis and you want to fix it, you can actually just curve that down and open up Guillon's canal and get everything. So now we're freeing the vessels up and coagulating all of the little vena comitans. Then we make an incision proximally. And there we have the ulnar artery, and we'll put a vessel loop around that. You can leave all those little branches. Now the nerve of Henle is talked about. I mean, I only find the nerve of Henle 1 out of 10, 15 times. I don't make a decision to look for it. So again, and then I place vessel loops. Here we do the radial artery, same thing. So I've put, now this is all done under loop magnification. And then we put vessel loops, that's good. So here's, after we bring in the microscope, so now you can see this is the blue on the right is right where the ulnar artery goes into the superficial arch, and now you have the 3 common palmar digital arteries. So we've taken the vena comitans off. This is that second layer that you want. This has the periadventitial tissue in it that has all the little nerves. You want to take that off. You don't want to take the adventitial off because obviously that would expose median, would not be good. And so you can see how you can just free all of this up. And it looked pretty good under loops before, but it looks, you see what we've missed when we use the microscope. You free all that up, and here's again, that's that little plane. So you slide in with the little micro scissors, blunt, hopefully. This is a very satisfying. You don't need to do very much. When we looked at this in rabbit ears, we painted them with phenol. I've never had the nerve to paint a human artery with phenol. It gave us a very good sympathectomy. This is quite, and there you see a branch from the nerve to the artery, and so we'll cut that. So you see those as well. There's the common digital nerve underneath. And you can flip it around and do all of that. So just move on here a little bit. Here's the ulnar artery. Sort of just do the same thing. Free that up, and then just real quickly. So here's how we do the dorsal, and you can pull down and get actually the edge of the deep arch. So this is the incision that we make. Now, I don't know if this is absolutely necessary. I think it helps. You know, how much is enough? Talk about, like Wendell has talked about, you know, extended incisions, doing it more is better. And that can't be wrong, but, you know, but how much should you actually do? I think this is helpful, and I've continued to recommend doing that. So we find superficial radial nerve and protect that. Then move the EPL and then open the fascia, and then you can see this is the radial artery in the snuff box. Now we're going down into the palm, opening the adductor and first dorsal fascia right there. And then you can get the artery right there, and then you can actually pull it up. Then we bring the microscope in, and you don't need to see this again. So we looked at the microcirculatory effects of this, and we did 7 patients with Raynaud's secondary to scleroderma, all were refractory with ulceration, not reconstructible, and we did the procedure I just showed you. Temperature improved, but was not statistically significant, improved just a little bit. Laser Doppler improved dramatically, and that correlated with increased symptoms. So postoperatively, total flow did not improve. Vasomotion or nutritional flow increased, and with that, symptoms decreased, and ulcers tended to heal. So it coincided with clinical improvement. Here's a study that Dave did looking at periarterial sympathectomy with a 31-month follow-up. 6 were ulcer-free. Some actually, if disease progresses, they get ulcers again. And there were no infections, wounds and ulcers healed in many. Ischemic pain improved in 19 of 22. So scleroderma, refractory to medical management, pain, and non-healing ulcers is the indication. So here's a patient, just quickly. Here's his original temperature. It's cold, it drops down and is slow to rewarm, and can improve. The technique we used, we already went through. This is at 1 week, the skin incision. So there's an article in literature that says these incisions don't heal as well as their 2 incisions did. You can't even see these incisions. In fact, sometimes I don't know if we've done operations on them. The key here is to keep that flap thick. So here you can see the temperature is improving, and the laser Doppler is improving as well, where it was 0. And you can see this at 15 weeks. So this is, you can see, baseline, it's not good. Temperature's better at a week, and at 15 weeks, and the ulcers heal. So when it's possible, you should do arterial reconstructions to improve blood flow, total flow, and nutritional flow combined with this sympathectomy. And this is the group that we want to do this in. So in summary, the majority of patients that we treat are operative, are treated, not we treat, non-operatively. There is a role for chemical sympathectomy with botulinum toxin. Sympathectomy is for refractory shunting. And arterial insufficiency requires reconstruction, and if possible, you should do that. What are the contraindications? Inadequate arterial inflow, they're not going to heal. So you want to try to improve that, but sometimes that's all you can do is a sympathectomy. Unfortunately, atherosclerotic disease, especially if they have calcific arteritis, it doesn't work, and that's been our experience. And there's now a paper that's published on that, and it's not a prophylactic operation. It shouldn't be done prophylactically in any way, including with botulinum toxins. Indications are AV shunting from nutritional vessels in which there's potentially adequate flow, failure of non-operative modalities, refractory ulcers, non-healing wounds. With digital amputation, we do this with digital amputation. It improves healing, and there's a paper that we've just finished that's being submitted for presentation and publication, and it's safe and effective when done as discussed. So I want to thank you for allowing me to share this journey with you. And thank you for allowing me to be the Jaiyoung lecturer, and for all he has done for hand surgery in the world. Thank you.
Well, Andy, that's a remarkable adventure and journey. That's been a lifetime of work from you. Andy started this work when he was a resident with a small refrigerator and a bunch of rabbits, and he has turned this into becoming the world's foremost authority on vascular disease, and it's an amazing career that has spawned almost 45 years of his life. So, Andy, congratulations, and thank you for a wonderful, wonderful, wonderful journey.
Certainly, I would thank you, and I wish I could be there with all of you.